Let me just start the meeting. Welcome everybody, and I'm really happy to announce that today we will have a presentation by Candace Chow, and she's a director of the education research in the Office of Medical Education, and also co-director of Promise to You, and an assistant professor in the Department of Internal Medicine at the University of Utah School of Medicine. Prior to this role, Candace served as an associate director of education research in the Office of Medical Education and was a research associate at the Utah Education Policy Center. She actually completed her postdoctoral training in the Center for Clinical and Translational Science and the Office of Health Equity and Inclusion at the University of Utah, earned a PhD prior to this in education from Cornell University, and is a 2012 Ford Foundation Dissertation Fellow. Her postdoctoral work examined how physicians understand their social identities within the context of privilege and oppression, and how these self-perceptions influence the formation of professional identities and physicians' interactions with patients. I think she still is busy in this field, and when we learned about her research, actually, it was via a colleague, also works on the CDG, and Clement Chow. And then he mentioned to me once when we met that his wife is working in a very exciting area of research with regard to workforce diversity and equity. And then we decided to invite her for a talk, and she was very nice to accept our invitation. And we really look forward to your presentation. So, Candace, the Zoom is yours, and thanks for coming. And after that, we might have some time for a short discussion and questions. Thank you so much.
Yes, thank you so much for having me, Tomas, and thank you for that introduction. So my talk is titled Professional Identity Formation of Minoritized Students and Faculty. What I plan to do over the next half hour or so is begin with a story. I think stories are really poignant and often more memorable than facts. So my hope is to present you a story that you can remember, and also that I think gives you a clearer idea of my motivation for this work. And then I'll walk you through 3 of the projects that I've been involved in that have to do with professional identity formation of minoritized students and faculty, and then I'll move into some implications. So my story, I grew up in New York City. I went to college at Cornell, and so I lived in New York State for the first 22 years of my life. And moving into teaching, which was my first profession, I was a high school teacher, the transition was actually pretty easy. And I think it's because so many people knew who I was. So many people understood that teaching was my passion. And I didn't have to do a lot of explaining to my community about what I was doing, because I was among people that I had known for a lot of my life. However, when I moved to Ann Arbor to do my 2nd, 3rd, and 4th years of teaching, I was confronted by several moments that made me just kind of stop in my tracks and question what was going on. So what happened was that every time I met someone new, whether it was a colleague in my building or someone socially, like at a party, a friend of a colleague, we would make small talk, and people would inevitably ask what it is that I would do. And when I told them that I was a high school teacher at Huron High School, they always assumed that I taught a specific subject. So now I'm going to turn things over to you, the audience, and ask if anyone can guess what that subject was. You can either use the chat or you can be really brave and unmute yourself. But what do you think the subject was that people assumed that I taught? All right, we have a couple of responses in the chat. Lots of votes for math, 1 for science. I'm sorry, go ahead, whoever unmuted.
Literature.
Literature, that's a different one. So yeah, actually I taught high school English, but everyone always assumed that I taught math. If not math, then people assumed that I taught science. And one time when I told someone, no, I actually teach English, they asked me if it was ESL. I'm going to go further and probe and see if anyone wants to explain why this kept happening to me.
I can explain, or I can try to explain. Sorry.
Sure.
I
Yeah.
think
What do you
I
think
think
was going on?
I think it's because of just the issues and stuff around quote unquote Asians being able to, do math and science or always in math.
Yeah. Thank you so much for volunteering that answer. Yeah. So there's an assumption that Asians are good in STEM fields. There are a lot of assumptions that we have about different groups of people in the United States. This is the way we've been socialized to think about each other and think about people that we come into contact with. And I was probably lucky that it wasn't until the age of 23 that I realized how much of an impact my appearance had on other people's assumptions of me. But it was at that point that I realized that even though I saw myself as an English teacher who happened to be Asian American, other people couldn't get past how I looked. And they saw me as an Asian American first. And then that is what influenced them to have these particular assumptions about me. So that's what motivated me to go into this field of study and to think about and question how social identity intersects with professional identity formation and how our social identities, those identities that we bring, that we've grown up with, for better or worse, how that influences the work that we do. So before I get into talking about the projects, I want to go over a couple of terms just to make sure we're on the same page. So professional identity formation is something that I've tossed around a lot already. It's simply the idea that when we enter a certain field of work, or sometimes when we just enter a specific workplace, there is a certain professional identity that we need to learn and take on. So when I was a teacher, I had to learn new terms like pedagogy and learn what lesson planning was. And learn particular techniques that you might use with students, like using a jigsaw. And these terms were specific to the specific profession that I was going into. I work in a medical school, and so a lot of times I hear that students also struggle with learning the terminology of medicine, and it's in learning that terminology that they feel like they can take on the identity of the physician. Sometimes professional identity formation also includes ways of dressing. So going back to medicine, wearing a white coat for the first time is a really big deal to medical students because it makes them finally feel like they're a physician because they look like everyone else in the profession. So that's what professional identity formation is. Social and personal identities refer to those groups that we belong to, which help define who we are. So I identify as an Asian American cisgender woman who is also a mother. And all of those identities also have a big role in helping me understand who I am, especially in terms of my group membership with other people who share those identities. And then lastly, I've used the term minoritized a bit, and I want to explain what that is and say why I like using this term as opposed to the term minority. So I think that minoritized helps to account for the fact that no one is a minority except when they are deemed by society as being the other. So minoritized basically accounts for the process that renders certain groups of individuals in the United States in larger society as minorities. And so that is why that's my preferred term when talking about these issues. Okay, so first study, this was entitled Whispers and Shadows, a critical review of the professional identity literature with respect to minority physicians. I know that word minority is there. That was a stylistic choice that the journal decided to make without consultation with the authors. But in this study, what we did was we conducted a meta-ethnography, and this is a meta-analysis of qualitative research. So we looked at 67 qualitative research papers published between 2012 and 2019. And what we were trying to do, we were all faculty who had already engaged in some projects around professional identity of minoritized physicians and trainees, but we wanted to do a more systematic review of the literature and use that review to outline an evidence-based research agenda for studying professional identity formation of underrepresented in medicine physicians. So what we found after looking at these 67 articles, and this was not a surprise to us because we were already working in this field, but what we found was that the literature prioritized a dominant perspective over one that supported the experiences of minoritized individuals. Some of these articles did not even touch on experiences of minoritized individuals because for whatever reason, the individuals conducting the studies had not thought to look at differences of experiences between those in the majority and those in the minority. And what we found was that there are 4 categories of what we call opposition, or you can think of them as categories of tension. So 4 ways in which all of these 67 articles talked about subjects, but in tension with each other. So the first one was individual versus sociocultural influences. And this was the idea that some articles talked about professional identity formation solely in terms of the individual, as if that individual lived in a bubble. And professional identity formation was just up to that particular person to take on the identity of the profession. Other articles talked about professional identity formation in terms of sociocultural influences and recognized that the context in which the individual was located, so their community, their family, the social groups they belong to, all of those things affected their professional identity formation. That was the first category of opposition. The second one was around formal versus hidden curriculum. We spent a lot of time talking in medical education about the hidden curriculum and how students learn how to be physicians, not so much in what they learn in the classroom, but what they learn from their classmates, what they learn on social media, what they watch their faculty do or not do. And so some articles talked about professional identity formation as being learned solely in formal ways, in didactic teaching sessions, for example, but more articles talked about professional identity formation occurring through the hidden curriculum, the ways in which students watched others and observed and figured out how to be physicians based on what they were observing. A third category of opposition was institutional versus societal values. So some articles only talked about professional identity formation in reference to the institutional values that a trainee found themselves within. So how, for example, the University of Utah does medicine and how trainees learn to be a physician specifically at that institution. Fewer articles talked about how societal values might also influence how a trainee learned to be a physician. And an example of this is there was one article that compared Dutch medical students to Taiwanese medical students. And the authors of that paper found that Taiwanese medical students were more likely to approach the field of medicine, the practice of medicine, in terms of their collective orientation to society, because collectivism was such a strong value in Taiwanese culture. And then fourth, articles talked about how an individual had to have space to negotiate this personal or social identity in the process of taking on a professional identity, and how that was really important to foster for trainees how to mesh those things together. Because if trainees were not given that opportunity, they often experienced dissonance in identity because they could not reconcile what they brought with them to the profession with what the profession was now asking them to do or become. So implications from this first study are that there isn't enough research on minoritized physicians. There is a growing body of literature. There have been more articles published since we published this article, but it's still very small. And then the second implication is that literature published to date often tends to be dominated by Eurocentric perspectives, and that we in the field of medical education might need to look to other fields such as K-12 education or higher education for how to study professional identity formation in minoritized individuals. The second study comes out of my postdoctoral research, and this was conducted at the University of Utah. So I interviewed 25 physicians, and I also conducted observations with them and their patients. And what I wanted to know was how academic physicians from all backgrounds understood social and professional identity, and then how these understandings of identity influence patient care. So the first finding was that physicians describe social identities differently. What I mean by this is that individuals who view themselves as being part of a minoritized group, whether it was because of gender or race and ethnicity or socioeconomic status, these physicians tended to talk about how those identities were brought into their identity as a physician. So an example is one of my participants said, "I think gender does make a difference. I definitely purposely wear my white coat most of the time, but even with that, I still get, I can be wearing my white coat and my stethoscope and ID badge and dress professionally and still have people say, 'We haven't seen the doctor all day.'" And this was a really common refrain among the women in the study, that they were not recognized as a physician, that if there was a man in the room, even if he was, lower rank, like still a trainee, he was deferred to as a physician. A lot of women who were physicians talked about being addressed by their first name by patients or by colleagues. And so the idea here is just that physicians who were minoritized in some way tended to talk a lot about how that social minoritized identity came into play with their identity in medicine. A second finding was that physicians also describe professional practices differently. So oftentimes physicians who did have a minoritized identity would talk about how that was actually an asset. It could be a way to connect with patients that they thought, those of the dominant background didn't have or couldn't capitalize on. So a couple of examples. This was a different woman in the study, but she said, "I treat almost exclusively women. I almost always hug my patients. Being a woman is an important part of that." And so this particular physician felt like having a gender identity in common with her patients allowed her to connect with them in a different way. This I thought was really interesting too. One of the physicians in the study who was from a lower socioeconomic background said, "I rarely wear a white coat because I feel like it's a charade." And for him, he talked a lot about how he felt like he didn't want to get away from his working class background and felt like it was very important to him to be able to connect with patients on that level and not appear to be too high above them. And so that's why he chose not to wear a white coat. The third finding is around the observations that I did with these physicians and their patients. And the finding here is that some described practices from my interviews with them matched what I was able to observe in practice, and some didn't. And the reason here is I don't think that any physicians were being disingenuous in how they described what they did with their patients or how they interacted with them. I think it's simply that I had a limited number of observations with each physician, and sometimes I just did not get to see everything that they discussed doing based on who they were seeing in their clinic that day. So implications from this project are that minoritized physicians have more negotiating to do in integrating social and professional identities. And this really connects back to my story. Not only did I need to figure out how to become a teacher in those first years of being a professional, but I had to figure out what it meant to be an Asian American teacher and how I fit into the field of teaching as an Asian American, in addition to being a new teacher. Another implication is that minoritized identity experiences can also be an asset in connecting with patients. So minoritized physicians in this case often face discrimination, but at the same time, they see how they can capitalize on those experiences of oppression to connect with patients. And then finally, we often talk about diversifying the workforce in medicine, especially because we want patients to feel safe with providers, and we want patients to be able to see providers who look like them or who have similar backgrounds so that they can relate more. And while I think that that is a really important thing to do, because the patient population is diversifying more quickly than the physician population, I strongly believe that all physicians need to be equipped to interact with minoritized patients, no matter what background that physician is from. Physicians need to embrace cultural humility and the ability to relate to patients no matter who they are. So finally, study 3 is about Asian American medical providers in Utah. This is a project that I'm currently working on. We're in the final stages of writing up the paper, but this has not been published yet. So some colleagues and I at the University of Utah conducted interviews with 23 medical providers in the state of Utah. All of these medical providers were either trained as MDs, DOs, physician assistants, or nurse practitioners. And what we wanted to know was, how do Asian American medical providers specifically, and those in Utah, understand social identities? And then how does this in turn affect professional practice? So I'm going to do some definition of terms again, just to make sure that we're on the same page, because I'll be using these terms as I talk through the findings. So the first term is the monominority. It's the idea that all Asians universally are academically and financially successful. Often this brings into play the idea that Asian Americans are really good in STEM fields, and also that Asian Americans tend to be passive. They keep their heads down, they do what it takes, they work hard in order to achieve that academic and financial success. What I want to tease apart here is the important idea that the monominority was not created in a vacuum. It was actually created for a very specific reason, and that was to drive a wedge between Asian Americans and other people of color in the United States. So the monominority was created in the 1960s, at the same time that many Black and Brown Americans were fighting for equal rights. Asian Americans were also part of that fight for equal rights, but that's often left out of the story. But the monominority was basically created as a way to say, hey, look at those Asians, they're doing really well. They're not asking for any more. Why can't you be like them? And so if we don't recognize why the monominority was created, we can get away from how insidious this trope really is. The other thing I want to point out is that you might say, hey, I've actually seen a lot of Asians in medicine or in STEM fields. All the Asian Americans I know are really successful. Why is this stereotype so harmful? And to that, I would say that the reason there are a lot of Asian Americans who have higher degrees is because of immigration history. And so the idea that you could not come to this country as an Asian for many years unless you either had a higher degree already from your own country, or you were coming here to pursue higher education, or you were coming here to work in a STEM field. So the United States basically selected for a very specific type of Asian person to come here. And that's why we see now, 30, 40 years later, that there are a lot of Asians in these fields, and that a lot of them are successful, but that's not the whole story. So that was a mouthful. The other term I want to go into is perpetual foreigner. This is a little bit simpler to explain. It's just the idea that Asian Americans rather aren't seen as American no matter how long they've been in the US. So every time someone asks me where I'm from, they don't want to hear New York City. They don't want to hear that I used to live in Ann Arbor, Ithaca, or that I currently live in Salt Lake City. They want to know what country I'm from or what country my parents are from. And that's not the same expectation that white Americans put on each other when they ask each other where they're from. So the perpetual foreigners, just the idea that Asians are unassimilable, no matter how long we've been in this country, will never really truly be regarded as Americans. So some findings from this study. The first is that our participants reported experiencing feeling like they were the other or feeling different. And these experiences of being othered included being stereotyped as monominorities or as perpetual foreigners, a feeling in between, and also feeling different because of other identities. So some examples of what this looked like. One participant said, so the monominority is kind of designed to make Asians look like, oh, you're supposed to be smart. You're not supposed to have a voice. You're supposed to just say yes. And yes, you should be a doctor. It's supposed to have good intention, but obviously that's not the outcome of those kinds of statements. Another participant said, I'm Asian American. We are not white and we are not underrepresented. So you're basically on the wrong side from both perspectives. And a number of the participants in the study did talk about this concept of liminality, or just existing in the in-between. This particular participant said, one lady gave me a letter saying, oh, you're just not the right fit as my provider. And that was because I was not the dominant religion. So another thing that participants in our study specifically had to contend with, because we're in Utah, was that not only were they part of the dominant racial group, but they were also not part of the dominant religious group. And that was another way in which they experienced feeling like the other. So a second part of the findings is how participants responded to these experiences of being othered. Some accepted it, some decided to take a stand, and then others talked about how, despite the discrimination they faced, despite the fact that they felt like outsiders, they still had pride in their identity. So participant 11 talked about accepting why their patients might constantly be asking them where they were from. And this participant said, I know patients here are into the whole genealogy thing. They've served missions everywhere. And so this was one example of acceptance, accepting that their patients were always going to ask where they were from, and it wasn't harmful. It wasn't meant to make them feel ostracized. It was just because they had an interest, because these patients had been to very different countries and wanted a way to connect with them. A second quote to illustrate the idea of taking a stand is one participant said, as a community, we have to step outside of ourselves and say, we have an obligation to the community because we're lucky. So this participant was drawing on the idea that as Asian Americans, despite the discrimination we face, we also have a high degree of racial privilege, in that we're not subject to the same physical harms that a lot of our Black and brown friends are subject to. And so this participant felt like, as a whole, the Asian American community really had an obligation to understand that degree of privilege and then be able to serve the community. And then finally, a quote to illustrate taking pride in one's identity. This particular person, and a number of people said this, but this particular person said, I share my identity with my children, so they at least have a healthy notion of who they are as Asian Americans. So a lot of the participants also talked, those with children, also talked about how important it was for them to share their culture with their children and have pride so that they could pass that on to their children. So implications from this study. Asian American medical providers in Utah experience stereotyping similar to Asians across the United States. We didn't find that Asian Americans in Utah had particularly different experiences, except ones that might be informed by Utah's local context, particularly with respect to religion, which I talked about a little bit earlier. And then finally, we think that it behooves the medical profession to understand Asian American medical provider experiences in order to retain and support them. And so I would say overall implications based on all of the work that I've shared today include studying professional identity formation of minoritized individuals is a relatively recent trend, and we need more of this work across the health sciences. Second thing is, when you don't belong to a dominant identity, you have to negotiate that and also learn how to adopt a professional identity. And then third, social identities do impact professional work and professional relationships. We may not always be cognizant of how this comes out, but it's happening, and we need to recognize and discuss this more openly. So the final slide I have is about just some of the things that we're trying to do at the University of Utah. So, and I can't take credit for this, this is the work of my colleagues, but at the University of Utah, we have a very, for the most part, homogeneous racial student body and also faculty workforce. And something that we've been trying to do over the years is help our students become culturally sensitive physicians who can really be wonderful providers to minoritized patients without putting the burden on the few faculty of color or students of color at our institution. And one thing we've been able to capitalize on here, at least, is the community health workers that we have in our community. So again, this is not work that I'm doing specifically, but my colleagues have started to partner with community health workers in teaching students because these community health workers volunteer basically to be representatives of their populations. And so they're engaged in teaching our students and providing guidance on how to work with racially diverse populations, patient populations. And something really, I think, unique to our institution is there's also a group called the Community Collaboration and Engagement Team. And what they've done is they have really strong connections, again, with individuals and various racial groups at Utah. And by that, I mean like Salt Lake City. And they've been available for consultation for projects. So one thing that I did when I was trying to launch the post-bac program that I co-direct is try to figure out, like, what is it that minoritized students need guidance in when they're applying to health profession schools. And this particular group was able to connect me with minoritized individuals across different fields and conduct focus groups with them. So that's a conclusion of my talk, and I'm really happy to take questions if there are any.
Thank you so much, Candice. That was really wonderful. You actually, I learned a lot, because we from Europe and came like maybe 10 years ago, and then certain things and terms, and also how would I say a phenomena that you described is very very unique to me, and then I think it was really an eye opener. Thank you so much. So I wonder if there are any questions. I have a few, but I will let the maybe the group first have the questions.
I just thought it was very interesting, again, that we come from a different cultural background, Eastern European. And when you asked me to guess what was your teaching experience, see, I was so sure it's English or literature, because I don't know why, but I never thought about you as an Asian American, but I thought about you working on these issues. And so it never occurred to me, because I think I'm just coming from a different cultural background, and certain associations haven't been met my brain. Don't you think it's interesting?
Yeah, it's so much about how we're socialized and how oftentimes we don't even realize the extent to which we have certain assumptions or associations with or about people until we stop to think about them.
Wow.
I just wanted to say thank you. I had your presentation made me think of something that I've been pondering on. It doesn't tie in all the way, but it highlights again that model minority, that sort of division that sometimes I feel is codified into, you know, our Constitution and old law. So not a lot of people realize, I started asking myself a few years ago, why is it that it seems like a lot of Asian American businesses are ending up in low income neighborhoods? Like you see them, you know, certain stores, you see them. So I started investigating, I think it's called the EB-5, which is the investor's visa. It's the one where if you're willing to invest $500,000, you can get a visa from the US and do business. What people don't realize is written into the language of that visa. It says that you have to go into, so the lower threshold, so the lower you are to like that $500,000 to $1 million mark, you have to go into communities that have high unemployment. According to, you know, the US government statistics. So where do you think you're going to end up at if it's high unemployment? You're going to end up in a lot of urban areas. And so it's even like in so many different laws, even after you peel off a layer, there's another layer of stuff. I just wanted to comment on that because as you were talking, it just jumped out to me when you were talking about the model minorities and how the laws, again, in this case, again, an immigration law, still is working to kind of bring this division.
Yeah, thanks so much for sharing that.
Other questions, maybe? I had maybe one because I mean, not personally, I mean, I was also asked that question, so where are you from? But usually they wait till I actually start to speak, because before that they don't know, you know, that I'm not an American, because I mean, but we have colleagues, you know, who are actually from Middle Eastern countries or African Americans, you know, and then this question is quite often asked. So how do you deal with that question? So what would be your suggestion to how do you actually answer that? So it's especially it's in a patient, you know, medical professional sort of situation. You don't want to basically tell something to the patient or educate the patient about this kind of stuff. So, but you have to deal with it. I think just accepting this question and swallowing the question and also the underlying sort of, you know, implications with this question is also not something that we should accept. But how would you advise us, you know, to deal with this situation, or how do you deal with it in your own experience?
Yeah, that's a really interesting question. All of the medical providers in the study on Asian American medical providers in Utah, all of them, every single one shared that they were asked where they were from by their patients at one point or another. Oftentimes it happened like daily. And their response was that it kind of depended on the level of patients they had that day. Patients with a CE, not like number of patients, but just like kind of how their mood was. And they could be dismissive at times if you know that level of patients was very low. But the bottom line was that the medical providers in the study tended to answer the question, just kind of like take it as it was, get to the heart of what the patient was trying, they knew the patient was trying to get to, so that they could then move on with the patient encounter, because they felt like taking care of the patient was the point of that visit. You know, it wasn't necessarily to educate the patient about the history of immigration of Asians in the United States and explain why asking where they were from was a microaggression. And you're right, I think a lot of times they just kind of like swallowed that and moved on in order to take care of the patient because they felt like that was the point of the visit.
Yeah.
But it came up a lot. That's something that was just universally shared. Richard, you have your hand raised. Did you have a question?
Yeah, yes, I do. First, thank you. I think that was an excellent presentation, and I think your opening was extremely powerful and illustrative, and all of the points through your manuscripts. When I currently work at the NIH, but when I worked in the hospital as a neurologist, we and my colleagues that of certain minoritized backgrounds, we would say one of the fastest way to become invisible as an African-American male in the hospital physician is to take off my white coat. Literally, if I pulled off my white coat, I could walk past colleagues that I see every day and they would not recognize me. All they would see is a Black man walking down the hallway. I think they would look at me a little differently with the white coat and assume, although likewise, people assume with the white coat that I've had the white coat and the stethoscope, and people have still asked me, in my transport, literally that happened in residency, to transport them in the hospital. But my point is, I guess it's a point and not necessarily a question. So I think you gave a great example. I think the problem is that these same types of prejudgments, it's one when a prejudgment is one that could be considered to be more positive, is placed upon a group or an individual. But just think how much more harmful it is when those prejudgments are negative, when people see you automatically, and the prejudgments that they have is that you're a criminal. My son is actually he's an ER physician, and he goes and hires ER physicians in other places. And he said he walked into an ER and the ward clerk asked him, my son has dreads, he's tall like I am as well. And they asked him, are you a doctor? He had on a white coat with the stethoscope. He says, yes. And the person said, well, you look like some of the criminals that come here in the ER. And so he was in a position to hire or fire the people in the ER. And so he just suggested that she get some more training at that time. But just to make the point that some of these prejudgments, and they're not positive to the individual on either side. If it's a prejudgment where people assume that it's something that's positive to ask that question, versus a prejudgment when it's something that is clearly negative. On either side, people don't appreciate that type of thing. But I just wanted to make that point that there are prejudgments that people have that are just outright negative that impacts people as well. But thank you again. I think that was really illustrative, and I really appreciate your presentation today.
Thank you much. Thank you so much, Richard, for sharing. I'm so sorry that that your son had to face that. And I, like, as I was listening to you say that, I know that your experience and your son's experience is not isolated either, which makes me really sad. So just thank you for bringing that up.
Tracy?
Hi, thank you so much for your presentation. I guess my question to you is, so, your point about, some of these models and like frameworks like model minority really being effective at driving wedges between groups really resonated with me. And I think, as folks working in, biomedical research, I think we still see some of that. Sometimes it's overt and sometimes it's more subtle. And I was wondering if you have suggestions or have seen strategies that are effective in, addressing some of those more insidious, what's the word I'm looking for, divisions, or constructed animosities between groups.
Yeah, it's a really hard question to answer because it's not simple. I think for me and like the colleagues in particular I'm thinking about are the ones that collaborated with me on the project on Asian American medical providers, because we all had the stance and understanding that we're like part of a bigger system, and part of the reason that there are these historical divides between us and other communities of color is because there are these misunderstandings. And because we've been socialized to think that the other person is the enemy. So I think for us it's just a matter of building personal relationships and becoming colleagues with people from different communities, so that we get to know each other as people and see that we're actually allies and on the same side. and try to have like understandings of the different perspectives that we bring. But I think that's where it starts.
Yeah.
Thanks.
Dale, you have also your hands up.
Yes, thanks so much. This really resonates with me because too many times I get to work and the security thinks that I'm the cleaner, I'm the only man of my color in a division. So I do consider extending this teaching to human resource in department. I think it's not only a good idea to share it with the medical school, but I think across, the Thai employment continuum that, it will really be good to have anyone, many people in the corporation, or whether, be including to things like this. And secondly, in your slide, you talked about a dominant group as opposed to the minoritized group. Have you thought of calling them also the non-minoritized group as opposed to dominant group? Because there might be groups that are not dominant, but also come into play when these biases or comparisons are being made across the community.
Yeah, I really appreciate that point. I have tried to figure out a way to also characterize what you're saying, like the dominant group is only dominant because someone decided that they were the privileged group, right? It just gets wordy to say non-minoritized. So if you have suggestions on a better way to frame that, I'm all ears. But I think that point is absolutely correct, and I should move away from using dominant. Maybe privileged group kind of gets at that a little bit better.
I have another question, and maybe not a question, but I don't know what it is, but I just tell the story. So we also here at Mayo, we teach the biochemistry and genetics class. And when you describe or actually present a genetic case, then you always actually identify the race and ethnicity of the individual. Or we were even actually brought to our attention that we tended to identify the race and ethnicity if it was not white. So, and then they asked, the student, that was actually coming back from the students, this feedback. So why do we need to know if it's a black or it's a Asian or an Ashkenazi Jew or whatever, the race or ethnicity was? And we started to have some sort of brainstorming. And it turns out that many of the cases, it has no relevance whatsoever, because this is not race and ethnicity, but more cultural backgrounds, or social backgrounds, why certain disorders or diseases more prevalent in a community than in another. But that has nothing to do with the race and the ethnicity. And then I was thinking, that, of course, I understand that we need to have all these statistics. So we always have to fill in, whatever we go in a meeting, we go wherever we go, we have to fill in what is our race or what is our ethnicity. And I was thinking that isn't that also, I understand why that is needed, and I think it is needed, but isn't that also that reinforces every time, that we are different? So there are Asians, there are blacks, there are whites, because we just continuously reinforced in that kind of, concept and social concept that we are not, as you said, allies in one big community, but we have these minorities, and then maybe we have. So I don't know what would be the solution, So I understand that we should do that because otherwise, certain things will never happen. But that is also something that sometimes can work counterproductive.
Yeah. So I think it goes back to why you're collecting the demographic information. So if it's for a specific purpose, for example, just going to illustrate how different ethnic groups within the Asian American population have different needs. If we can disaggregate data by ethnicity, and the AAMC has done this, you can pull up information about which students from which Asian ethnicities have applied to medical school. Disaggregating data like that helps to show that even though Asian Americans as a whole look like they're applying to medical school in full force, there are actually very few Southeast Asians applying to medical school. So very few Laotians, very few Cambodians, very few individuals from smaller Southeast Asian countries. And looking at data disaggregated like that gives you a fuller picture of the heterogeneity within the Asian American population. So I think when you're collecting demographic information, whether it's race or gender or socioeconomic status, and you have a very specific purpose for collecting that information, I think it can be very useful. But if you're just collecting it for the sake of collecting it, then maybe that doesn't need to be done. And then to your point about including demographics in case-based learning, kind of, I think, is what you were getting at. You're right. I think there also we have to be careful of how we're using things like ancestry and whether it's necessary in helping students understand diagnoses, or whether it's for further reinforcing stereotypes about particular social groups, and that particular groups are only prone to having particular diseases. So
Yeah,
maybe no simple
exactly.
answer, but I think you just have to be really thoughtful about why you're doing it, and what the point is in both those instances.
The same, it was mentioned, a few times that, like especially now Black colleagues, they were identified as criminals, and this is really surprising and unacceptable. But that's the same story. So I never really understood that. What is the relevance, in reporting, to actually identify the race and ethnicity of anybody who does something, which is unlawful, because it has nothing to do with the the ethnic background. I mean, this was a burglary, or that was a murder. That's nothing to do with that. But it's every time in the reporting. So I think that maybe should be the first thing to get rid of that kind of thing, because it doesn't carry any information for the general public. I can imagine maybe for the law enforcement officers, to find somebody, it can help, but it does not have to be in the general reporting, because that also reinforces these kind of stereotypes all the time, and then many of the other reporting always identifies, these backgrounds, or ethnicity. And I think this is, but I don't know how to change that. I guess there is a slow movement, and we might be further than we were 10 years ago, but it is a slow process. Richard has again some.
Yeah, no, it was just a question. I had to sit on my hands with the question, because I think it's a very, the answer is, it's a very complex question, and the answer is very layered and nuanced. But I think that Dr. Chow, you gave a great answer in terms of, and the NIH mentions that as well, that if you're going to use race in science, that you should have a justification in terms of why you're using that, and know the reason that you're including it and what you're looking for. However, on the other side, we do know that in medicine that there are, like, for instance, I'm a stroke neurologist. We know that race, which is a social construct, but it is a risk factor, that we know it's 2 times more common in African Americans and 1.5 times more common in Hispanics. And so if you have a person who's African American or Black or Hispanic that has this higher risk, it's important to mention that to them. And so when I was an attending talking to students and trainees, I told them to mention that, because that is a risk factor and people need to know that. We know it's also important when you think of clinical algorithms as well, when you think of the glomerular filtration rate, which for a long time it included race, African American. Now, we know that there are some biases created by including that, but we know that there are different pulmonary function tests and other things. So there are instances where it's needed. I participated in a panel through the National Academy of Medicine, where they were looking at, should we take race out of clinical algorithms or keep them in? But we know that race is a very strong social driver. So it's not a biologic variable. And so in science, you do have to think about why you're using it, but we know that clinically it does have an impact, as well as the social things as well that you mentioned. I think that was there were multiple components to the question. So I just wanted to.
I mean, it's a very multi-layered and complex issue. I agree. And just to respond to your point that you said, I understand that there has to be some reason, to collect a certain kind of information. My point was in that, that maybe the institution or the governmental agency collecting that information has exactly the reasons, and then they can argue and they can but it's never in the questionnaire. So I don't know what that reason was. And I only see that if I'm white, black, Asian, whatever. So that's what I mean, that without having that kind of, explanation that why you collect this information now, you're not educating me on anything. You're just reinforcing that we have different races and ethnicities, because it's a simple question that what is your race or ethnicity, or how do you identify yourself? And it's never clear to me why they collected the information.
Yes, so
Well, not always.
Dr. Chow was, her answer was spot on as well. The American Academy of Neurology, I actually led a group. We looked at the Axon Registry, which is a registry of neurological patients. It's the largest outpatient registry of neurological patients in the country. And we tried to look to see if there were disparities in terms of how the patients were treated. And we found a lot of missing race and ethnicity data. And so what we're doing, because of that, you can't look at disparities if you don't have that information. So we're suggesting
that is true too. Exactly.
That medical practices, that they do educate their front office staff, and they create scripts for how to collect this information from people and explain why we're collecting the information, because it is sensitive for a lot of people. So I'm sorry, I didn't mean to. You touched on an area that I work in and talk about, so I'm sorry, but I just want to make those points.
Yeah,
Any
I
other
appreciate you.
questions from the group? Yeah. Candace? Any questions from the group? Because we are actually top of the hour. So I really would like to appreciate your coming to talk to us about these very important matters. And I think it was an interesting discussion. And we may actually ask you sometime later to come back and maybe tell about your research, as I see you continue in this field, and then you are just about to publish some new exciting data. So I really appreciate you coming to talk to us, and everybody joining the meeting today. And see you then. I think we'll email you about the next meeting, and the next. I think it's going to be in December. Maybe Sheridan can help me out. Yeah.
I'm pretty sure you're right. I'll send out a reminder, but I believe you're right, December.
Thank you so much for joining us, and have a wonderful afternoon. Thank you. And thanks, Candace, again for coming and talking to us. Thank you.
Yes, thank you again for having me and for all the questions. It was really engaging for me to have a dialogue with you at the end. So thank you.
Thank you. Bye-bye.